Yeah.
Nice. So let's begin. Our role this evening is to introduce you to RESP. Basically, we're going to take you through the pulmonary RESP conditions, how they present, how you'd examine, how you'd ask questions. But as of right now, we'll start off small. We'll just start with how to take a history. Yeah. So that's why. So we're gonna take deep breaths in, deep breaths out, and then let's begin. So when we talk about a RESP history, do you guys remember the components of a history? I'm sure you did from last year. There was PEDS and OBS, yeah? You can just say yes. You can just say yes or no if you have ever taken a history before.
Yes.
Lovely. So now we're going to do how to take a RESP history and also how to like it, because at some point it's going to be monotonous. As Savimbi and I would later explain, like the closer you get to the end of rotation, the more monotonous it is, and the more you just feel tired. But for now, you're just fresh. You're just fresh. So this should be interesting. So we're going to look at biodata. We're going to look at presenting complaint. We're going to look at history of presenting complaint. These are very deep. Now, the history is where you expand on the presenting complaint. Then you come into your past medical history. And if your patient is a female, then you insert your OBS-GYN history just over there, as in just a short segment just for OBS-GYN. Like you ask them how many kids they had, whether they ever had a miscarriage before. I'm sure I'm sure third year has taught you all this. So I won't dwell much on it, even in my subsequent slides. I won't dwell much on it because I'm sure you already know how to do an OBS-GYN history. Family social history, there's some consoles like those in 1B. Dr. Oyero, who's a very huge fan of a family social history, like this one has to be immaculate for him to like listen to you properly. Then there's some others. Then we come to review of systems, where you'll have to dissect each system at a go. Like, did you have you've given them, the patient has told you that this brought them to hospital, yeah? So now you're going to ask, did anything else occur around the same time? Like in our case, we're going to focus on RESP. So did you have anything like a headache before that? No. Any this? No. Any that? No. Okay. Then you summarize everything. Well, you give the highlights, the biodata, presenting complaint, and the duration, as well as the important negatives. We'll explain all of that as we go along. And then we'll do a general examination and a systemic examination right there. So I will be taking you through biodata all the way to summary, and Savimbi will be taking you through the gen exam and the systemic exam. This is where we move from theory to the nitty-gritty aspects of clinical works. That's where this is where we'll come for you right over there. Okay, so moving on. Biodata. So here's what you need to know in biodata. There's the usual stuff like name, age, residence, occupation. But then now here's the catch. In RESP, you actually, aside from asking name, age, and then residence, and then occupation, and then just leaving it like that. Like, let's say this guy is, let's use me for an example. David, 23 year old, lives in to Hurlingham, occupation, he's a student. Now, in RESP, you have to ask them how many years have they been in that occupation? How many years have they been in that residence? And then it's also not just enough to ask them how long they've been in that place. You also have to ask them how long have they been there, and before then, were they in a different place? And how long have they been in that place? This is important because there's some occupations that predispose you to a RESP condition, like coal mining. There's some residences that predispose you to a RESP condition, like Limuru, where it's very cold. You can get asthma from there because one of the risk factors of asthma is cold areas, or even thicker. Thicker is very dusty right now. So maybe if you live in a dusty area, you can get something like uh, TB or pneumonia, one of those. Like it's very critical that you get that aspect. you need to ask the number of years that they've lived in that area or done that particular job, and how long, and before then, even before that job, even before where they live now, have they lived elsewhere? Have they done work elsewhere? And how long have they done it for? Okay. The example here I've given is, let me just do this. The example here I've given is the patient has lived in Kangemi for 50 years, but prior to that has been a Guru resident in his child. Simple, like that's very straightforward. He lives in Kangemi, and then now for 15 years, but before then, as a child, Limuru. And then you also need to go ahead and ask more details, like date of admission. DOA is date of admission. Then the current medical status. Have they been on any medication prior to admission? Are they unknown? Are they living with a disease, a chronic illness? Are they? You'll find some people who come to you presenting with a cough, but then when you ask them if they've been on any drugs before, they'll tell you, yeah, I've been on this drug called rifampicin or isoniazid. And you ask them why, because normally those drugs are not given to just anyone. Then they'll tell you that, oh yes, I used to have TB like 6 months ago. So right now I've just finished it. I'm actually just finishing it right now. I love this is what's happening. Now, I'm sure you guys have done pharmacology, like it's still fresh in your mind. So when you ask them what the RIPE regimen is, can someone tell me what the RIPE regimen is? Like, what are these RIPE? Just someone, you can mention it in the chat, or you can just unmute and say.
It's rifampicin, isoniazid, pyrazinamide, and ethambutol.
Lovely. And what is the condition that they are used to treat?
TB, tuberculosis.
And do you know how long you use it for?
Yeah, I think if you use rifampicin and isoniazid, the combination is usually 6 months, and 9 months. I'm not sure. I think 9 months, and then if you add pyrazinamide, it becomes 6 months.
Okay. And yes, that's very important, because now when you ask them how long they've been using it, now you come to the aspect of adherence. Normally, some people say compliance, but then compliance is a lab word. You can test for compliance, but you can ask for adherence. That's the nitty-gritties. Like someone who's in 7B. Is there anyone in 7B right now? You'll meet this prof called Prof Amaya. He's very keen on this. Hey. Let's just say that he used to insult me a lot, but moving on. And then also another thing is, you'll see some chronic conditions such as TB. You'll even see someone with HIV there. And that's why you need to ask, are they on ARVs? Which ones are you on? And are you adherent to these drugs? Do you take them? Some will say that they are take them on and off due to financial difficulties. Others will say that they don't feel like the taste is weird. But it's very important to ask. And even for those who take them, you also need to ask, have you felt anything different in you since you've taken the meds? Because there are these things called adverse effects, side effects. Like pharmacology is still fresh in your mind, so I'm sure you know this. Adverse effects, drug interactions, very important to ask, because they could predispose you to a rest condition like ACE inhibitors. If you continue using them, you'll develop a dry cough. That's a side effect of those inhibitors, a dry cough, which can be a presenting complaint. Okay, I think I can move on. So now on to the next part, presenting complaint. Here's where we now mean business with this patient. We're at the core, at the crux, at the crux of the matter. This is where you and the patient now talk about what brought them here. So you have to use open-ended questions. You don't restrict them. You just give them a nice question like, nini ilikuleta hapa? Like, just from there, they will talk. Patients love to talk to people who seem like they're listening. So also be respectful when you're asking that question. Don't be like, sasa nini ilikuleta hapa? No, just say, what brought you to the hospital? May I ask what brought you to the hospital? Then the conversation flows. Like you don't treat them as as something in a book. Treat them as a human being as well. That will help. That will go a long way to help you. Okay. And in the presenting complaint, what we really want to know are the symptoms and the duration. Symptoms and duration. So you say they had now this patient tells you, oh, nimekuwa na kikohozi kwa siku mbili, I've had a cough for 2 days or chest pain for 1 week. Those are the things. You just list them down and write in the patient's words. The consultants will always tell you, write in the patient's words. Don't be a show. If they say they've had difficulty in breathing, write difficulty in breathing. Don't go ahead and write medical terms like dyspnea. Yeah, be down to earth, please, because they'll ask you, did the patient tell you that they had dyspnea? No. Then why did you write it? Yeah, that's how they go. That's how they usually are. Yeah. By the way, I hope this is recording.
David.
Yeah.
I may add something. When writing the presenting complaints, please try to keep it to 3 or 4 maximum. Because the thing is, if you do have way too many presenting complaints, it also becomes an issue. And then there are some presenting complaints that you can associate with one another. So, for example, hotness of body. So we normally don't say fever, because fever that's something you'd have to check with like a thermometer. But hotness of body is a better word. I mean, better term to use. So, for example, if you have 3 presenting complaints such as cough, chest pain, difficulty in breathing, that's already 3. Down there in the HPI, I think it would be best if you associate it with hotness of body.
Yes. Yeah, that would work. Yeah. And also another keynote, you write your PCs according to how they presented, like from earliest to latest. Like let's say cough, chest pain, and difficulty in breathing. The difficulty in breathing happened 2 months ago. Then the chest pain happened 1 week ago. Then the cough happened 1 day ago. Which one would you start with? Would you start with the one that's at 2 months, 1 week, or 1 day? This, I'm opening it up to you guys.
Two months.
Mm-hmm. Yeah, you start with the 2 months. So you go chronologically. That's actually the word they use, chronologically. So you start with the one that's very early, 2 months, then you come to 1 week, then you go to 1 day. And also be very understanding with these patients, because there's some patients who just love to yap. People buy, I'm not throwing any shade, but there's some patients who just want to talk. So you kind of have to gently guide them back to they'll speak about something that's unrelated. So you just bring them gently back to the topic, as you just yes, nimekusikia lakini tena unaweza niambia pia kuhusu hiyo uchungu hivyo, then you proceed. So, okay. So, common respiratory features that you are likely to get. This is in the RESP wards now. There are some patients who will tell you that they have breathlessness, while they complain of difficulty in breathing or shortness of breath. Quick question. Which one is more likely to be a cardiac terminology, and which one's likely to be a difficulty in breathing or shortness of breath?
I think shortness of breath is more likely to be RESP. Yeah, I'm not sure though.
Okay, anyone else?
Shortness of breath, most likely cardiac.
Anyone else? I need 3 people to answer. So far, two have answered. Then I say. Just one more person. Just one more person on game.
I think shortness of breath is also cardiac.
Now, thank you for your answers, all three of you. I'm here to tell you that when you write your presenting complaint, depending on where you are, difficulty in breathing is more cardiac, CVS. So when you're in the CVS ward, you can write DIB, difficulty in breathing. But then when you're in the rest ward, it's usually shortness of breath. So that's SOB. SOB is in the rest ward. Yeah. There's some nurses who will even tell you that in both wards. They'll just tell you when you're saying this, just write DIB here. In 7C, write DIB, but then in 7D, write SOB. I don't know why. I don't know why it's there, but it's there. And then for cough, I think you already know what this one is. I'm not really going to explain much. Then sputum is just a collection of mucus. When you cough, you're coughing out mucus and it's mixed with water, some cells of your trachea, bronchus, and some microorganisms that have caused that issue and particles as well. Then hemoptysis is just sputum with blood. Don't laugh at this one. This one is actually really, really urgent. Like when you start coughing blood, just know, hey, things are not looking good. And then wheeze is noises from the chest when breathing. I'm sure it's not snoring, it's just snoring is when you're asleep. Now, wheeze is when someone just breathes in and out and then you hear noises. Just breathing creates noise. And this is not just that because they've just had an exercise session. This is just regular breathing and they're making noise. That's also a complaint. Also chest pain. Chest pain, now this one, it's a bit difficult because it can be a resp issue. It can also be, I've also been told to differentiate between wheeze and stridor. Now, a wheeze is mainly expiratory, and it's not as high. Okay, now it's not as high pitched as stridor. Stridor is the high pitched sound that occurs during inspiration. Like someone breathing in will create a very high pitched voice, like if you breathe in, it will come out like something like that. And then breathing out will be the noise that comes out when you're breathing out. That's wheezing. Yes, and wheezing is mostly in asthma. Yeah. Okay, there's some differences. Like stridor is mainly in the. Okay, stridor is because of a foreign object. A foreign object that is blocking the main airways. Wheeze is because of the smaller airways that are being obstructed. Okay. Now, chest pain. On to chest pain. Chest pain is very weird because it has three sources. You can get chest pain because of respiratory issues. You can get it because of CVS issues. You can also get it because of GIT issues. Now, I think I'd have to explain why. So, in RESP, you'd get it because breathing in, breathing out is weird. For cardiac, have you guys ever heard of something called myocardial infarction? Feel free to just say yes or no if you've never heard of an MI.
Yes, we have.
Okay, so when you talk of MI, we usually say this is how to differentiate between a RESP and cardiac issue, because usually on a cardiac issue, it's left-sided chest pain. Sana, it's left-sided chest pain. And for an MI in particular, it radiates to your arm, shoulder, neck, and all that. Whereas for RESP, it's just around your chest. Like breathing in and coughing makes it worse. As for your GI, GIT chest pain is usually because of, okay, random anatomy question. What organ of the GIT is usually around the thorax? Like there's an organ of the GIT that's on your chest, just on your chest, like
Esophagus.
yeah, esophagus. Now, when that happens, when there will be something, there's something called esophagitis, like inflammation of the esophagus. When that happens, you'll get the chest pain. Also, when you have something called GERD, the reflux, gastroesophageal reflux disease. That one can also cause the pain, but in that circumstance, we call them epigastric pain. Epigastric pain can also be chest pain due to a GIT issue. I'll leave that. There's some other conditions that can cause chest pain from the GIT, but I'll leave it to the gastroenterologist to answer that as I move on. My main focus right now will be just the RESP case. Okay, so here we are at HPI. Here is where you're going to talk. You're going to yap. You need to bring out the inner yapper. You and the patient are now going to talk. You're going to bond in a way. Like the patient says something, you ask, give and take, give and take. It can be rapid, it can be slow, depending on your pace. Just know that you and the patient will be talking. This is now the bulk of your history. This is where the consultant will like lock in. When you're presenting, they'll lock in. They'll be like, okay, let's listen to this one. Let's listen to this lady presenting. Okay, now I see. Now, there's usually a format so that you're not lost when you're asking more about their presenting complaint. So there are two mnemonics. There's operate and there's Socrates. Operate is everything else aside from pain. Now, Socrates is the one that's used for pain. So operates, there's onset, progression of symptoms, exacerbating factors, relieving factors, associating factors, timing, previous episodes, and severity of current episode. And then for Socrates, you look at site, onset, character of pain, radiation of pain, associating factors, timing of the pain, exacerbating or relieving factors, as well as severity of pain. I'm sure Socrates is the one that most of you are well oriented with. It's operates that's very different. But both of them asking the same thing. It's just that operates doesn't have site and characters. So, nice question. When you say progression, it just means, yes, this symptom has occurred right now, yeah? So has there been any change has there been any change since that time it started? Let me give you an example. This patient has said that they have had shortness of breath for 2 days, yeah? And it occurred suddenly. It was acute, sudden in onset. Progression. Now for progression, you ask, how did it start and how is it now? So at first, the shortness of breath occurred when they were just moving around, just walking, exerting themselves in strenuous exercise. But then it has since progressed, even at rest, even just getting up, dressing and undressing brings out the shortness of breath. That's what we mean by progression. Like, has there been, what change has there been in the symptom ever since it started? Is it yeah, basically that's actually how progression is just how the change of the symptom is since it started to how it is now currently as the patient is taking. Any other question before I move on? Okay. So now I'm just going to dwell on each presenting complaint here. So when you talk about breathlessness, in this case, shortness of breath, This is normally associated with COPD, chronic obstructive pulmonary disease, asthma, pneumonia, among other risk conditions. When doing your operates, always remember to ask your associated factors. Now, when you talk about breathlessness, there are some associating factors. There's orthopnea, difficulty in breathing or shortness of breath when changing positions. There's exertional dyspnea, when just moving around, when they're exerting themselves, just moving around, using their body to move, they already like. And then PND, paroxysmal nocturnal dyspnea, which happens at night based on the word nocturnal. As in, they're just sleeping and then kidogo, they find they can't breathe. So now they have to sit up. They have to sit up so that their lungs have that, so that their airways have enough room to expand, and then air suddenly flows in. And then in timing, is it worse in the evening or in the mornings? Because asthma is usually worse in the nights and early mornings. And then there is a way to grade them, which is now in CVS, you'll be told about the New York Heart Association grade. Is grade 1, 2, 3, 4 in Roman numerals. But now here in RESP, we have the Medical Research Council grading of this. And they occur in 5 stages. 1, not troubled by breathlessness except on strenuous exercise. That should be the normal. This is the normal. And then 2, short of breath when hurrying or walking up a slight hill. This is when you know things are a bit tricky. And I'm sure some of us here are at grade 2. I won't mention anyone. I'll just say, okay, there's myself, number 2. And then there's number 3. Walk slower than contemporaries on the level because of breathlessness or has to stop and walking at his own pace. This is someone who's beginning to show signs of resp failure. As in, now they're walking on flat ground, but then they have to stop a bit. Why? Because their lungs are not looking good. They're having visions of impending doom and death just because they can't walk. 4 is where things are a bit tricky. This is where now this is actually the stage where someone is like, hey, by the way, let me start going to the hospital. Some. So they stop for breath after about 100 meters or after a few moments on the level ground. And just walking from here to the door is already hemming you. Hey, you're like, hey, something's wrong here. And number 5, because most people do not care about their bodies. This is where most people actually start going to the hospital. Because they're like, hey, no. So, oh, my audio is breaking. My bad. Can you guys hear me now? Okay, lovely. So number 4 is where some people turn up to the hospital. And then number 5 is where most people now, because people don't care about their bodies, this is where they start saying, hey, let me go to the hospital, because they're too breathless to leave the house or breathless when dressing and undressing. This is where any small movement, you already have mind. You're like, hey. Then let's move to cough. So a cough can be either acute, which is less than 3 weeks, or chronic, more than 8 weeks. And subacute is in between 3 to 8 weeks. So it can be dry, like pulmonary fibrosis or side effects of ACEIs, or productive disputa, like typical pneumonia, COPD, and the others. So for this, cough, when you're asking about cough, when you're doing your operates, focus also on the timing, because a dry cough at night can lead you to asthma. Like, that's the diagnosis. Patient presents with a dry cough at night, you're thinking asthma. Then also exacerbating factors like dust, cold, you're like, could it be an allergic asthma? Okay. Also important when you're talking about cough is smoking history. Smoking, because there's some chronic smokers, long-term smokers, who all of a sudden when they say, let me quit, they also start coughing. So when you cough and you're a long-term smoker, you're querying either COPD or malignancy. Like unacheza bets. Yeah. Between the two, you're either thinking COPD or malignancy. Now for you ask whether it's produced during the cough what color it is and quantify it if possible. Like this is where you now ask the patient. There's usually a cup next to them. Like you ask them, inajaza kiwango gapi ya hii kikombe? Like you give them a definite measuring object, and then they pick the level where it's at, and then it's up to you to verify the estimated or approximate amount. So for the color, white and translucent just means a viral infection, like bronchitis. White and foamy would be pulmonary edema. Yellow-green is bacterial. That's usually a purulent. They call it purulent because that's pus. The yellow-green there is pus. Green would be an indication of a pseudomonal infection. Grayish is pneumoconiosis or a waning bacterial infection. Blackish brown is possibly old blood and also should be further investigated, but could be harmless. It's a could be. But then if your sputum is easily broken up, that's usually a tuberculosis or an actinomycosis thing. Then hemoptysis. Now, these were things that get a bit, so this is where blood comes in. Like now you're coughing out blood. So causes of pulmonary hemoptysis. There's the infection, which is the most common. So it can be an acute, viral, or bacterial. It can be TB. Okay, here, funny story. There was one time I got pneumonia and I coughed out blood. I freaked out, thought it was TB, but it's just pneumonia. Anyways, acute, viral, or bacterial, yes. So TB can also cause hemoptysis. There's also aspergillosis. Now this one, the color can differentiate. It can either be red or, what's the other color for aspergillosis? Subs. Aspergillosis can cause a different.
I'm not too sure about that.
I think it's brown.
Maybe one of you guys can tell us.
Could be brown. Yeah, by the way, please tell us. Because it's a very big thing when if you see someone saying that it's this particular color, then it's definitely aspergillosis. I think then I can just say, at least I hope I can say. So it's usually a brown. Oh, there's someone who's written. So aspergillosis usually causes a brown color when it just comes out. It can be brown with red. That's usually aspergillosis because aspergillosis is caused by a fungus. I won't ask you the fungi itself, but okay, anyways, it's just Aspergillus fumigatus. Yeah, those are the common fungi. And then you can also have neoplasms. That's a nice word for, say, cancer. So bronchogenic carcinoma, which is the second most common cause. You also have bronchiectasis, cystic fibrosis, and then you have lupus pneumonitis due to SLE. SLE will be covered later on. Very interesting. But for now, we'll just leave it. So also remember to ask about trauma to the chest when you ask about hemoptysis. And when you're dealing with hemoptysis, you ask whether the blood is fresh or not, when it started, and how much and how often. That's usually the thing. So you ask about how much, how often, when it started, and if the blood is fresh or not. Because sometimes you can confuse it for a nosebleed that's dried up, and then now you're trying to, oh no, but he coughed out blood. No, it's a nosebleed that happened, and then now he coughed it out later on when it's clotted. Yeah. Now, these are just causes of hemoptysis. There's usually an acronym for it. It's called battle camp. I won't go into it as much because I think time is not enough. So wheeze is usually, I think we already talked about those. those sounds. So it's usually associated with asthma, COPD, and anaphylaxis. And chest pain. Ooh, chest pain is very tricky. But if you're in the rest pod and then they say they have chest pain, it's usually pleuritic. What do you mean? What do I mean by pleuritic? It arises from the pleura of the lungs, those coverings. So it's usually made worse during inspiration and coughing because of inflammation of the pleura. That's in most cases. But if you find it's more constant or easily localized pain, like it's right-sided chest pain that never seems to go away, that's usually a tumor. Yeah, really, really bad. But it's usually a tumor, either lung or pleural, or a consolidation. There's something there. Okay, and just to finish up on HPI, don't forget to ask about systemic features or B symptoms. B symptoms are the fatigue, night sweats, weight loss, fever. These can be used to rule out malignancies and severe COPD, and also an aspect of TB. TB can cause B symptoms, by a favorite thing we used to say in fourth year. TB can cause everything apart from pregnancy, because anything in the world, any condition, you can almost certainly attribute it to TB, because TB is TB can go all systems, like spine, brain, meningitis, it's there. Lungs, definitely, it's there. Bones, it's there, even. Yeah, so past medical history. Okay? So we're looking at previous admissions, surgeries, history of blood transfusion, whether they were a donor or a recipient. We're looking at past medications that are now unrelated to the illness or that system, any known food or drug allergies, and then you also query any chronic illnesses like cancer, RBD. We don't say HIV, we say RBD, to be respected. Okay. And then there's a mnemonic here you can use, like thread. So you ask about TB, T for TB, hypertension for H, rheumatic heart disease. This one you ask for the signs, like those polymigratory arthritis, ISO, the nodes, ISO, you ask about those. You don't say the name of the disease because they definitely don't know. Yeah, you ask about the Jones criteria because they definitely don't know the disease. So you just say, umewahi pata hii? Have you had this before? Have you had that before? Yes. Epilepsy, kifafa, as in just fainting and seizuring. You ask about asthma, you ask about diabetes. So this one and this one you should have asked in your HPI, but you can also ask them again here. Okay, let's move on. Family social history. Now, this is where I was telling you about this particular doc who likes family social. 1B, 1B. If you're in 1B and you meet Dr. Yiro, please have a nice family social history. So, in now to bring it into the context of RESP, I know you already know how to ask a family social, but now I'm going to tailor it to a RESP case. So you ask about family history of RESP illness. Has anyone in your family ever had this disease? Ya kitu ya kifua. You ask them everything, because cystic fibrosis, I think, has an aspect of genetics. You can check that. You can verify that. But cystic fibrosis can be genetic. It can be hereditary or whatnot. Something along those lines. You also ask them, and please be empathetic, like have some empathy. You ask them if family members have died and what they died from. You don't just say ati baba yako alikufa, alikufa juu ya nini? Okay, I've been told that CF is really a white people, but we never know. Yeah, okay, yeah, but it's predominantly a white people disease, so you don't need to worry about that. But all the same, please just ask about your family history. And also ask if your family members died and what they died from. Yeah, and please be a human. That's actually what these docs actually want. Be a human being. So in your social history, oh yeah, and age of death. You also ask them at what age did they die? Yeah. Now in your social history, this is where you go into the nitty-gritties. You don't just say for one and then leave. You ask them accommodations. Is it clean or dusty? What kind of house is it? Is it an apartment? Is it a house where it's party? Is it a house where I can open it with a wembe if I just think about it very nicely because it has paper coverings? Small stuff like those. Is it well ventilated or not? Also important, especially in RESP. In RESP, ventilation is so important. Ask them what they cook with. Do they cook with gas? Do they cook with charcoal? Do they cook with kuni? Do they ask, just ask. And then their lifestyle. Do they smoke? Now, if they smoke, can you do a pakias? I'm sure you know how to do pakias. You guys know how to do pakias? You can type yes or just answer, or yeah, you can type. You can type or answer when unmuting. Okay, I'm going to take silence as an answer. Alcohol, there's also alcohol. Yeah, alcohol. Now, when you ask about alcohol, you ask about how long they've taken it. You also ask about other recreational drug use like cocaine, heroin, bang, bang. Hobbies like gambling that can lead to sedentary lifestyle, exercise habits. I asked about another thing you need to ask. Do they keep pets? Yeah. Do they keep pets? Hobbies. Some hobbies are very weird. Do they like keeping cats? Are the cats immunized? Do they shed fur? Because there's some people here who can't keep cats because they're allergic to fur. And now their occupations, you ask them, because the RESP system is so intricately tied to your occupation, such that it's normally the first thing. Okay, there's some cases where GI is the first thing, but there's some, most often than not, it's the RESP system that is affected first. Like, you're in a workplace that has mold in the ventilation system, you will immediately get some RESP issue. Like, you'll start coughing. And when you get out, it's actually called work-induced asthma, allergic, because you get RESP issues while in the office, but then when you're out of the office, you're fine. You go back in, you start coughing again. You go back out, you're fine. Now, just to bring it closer to home, like people who are poultry farmers. Poultry farmers have risk of getting something called pneumonitis. Coal miners, they have this thing, or the black lung disease. People who mine asbestosis. There's something called asbestosis, and so on. Do they have, okay? And also, when you're asking about their social history, you come back to their family lifestyle. Do they have some sort of social support system? Are they cared for by the family? What is the situation at home now that the patient is here in the world? Do they visit him, or like, be a human? Yeah, that's my point. Be a human. Like, look after your patient. It's now your patient. He or she is now your patient. Yours. Ask them anything. Like, make them feel like they are listened to, because that's also another factor of a doctor. Apart from being the medical doctor, you also a humanist. Okay, and then you also ask, what can the patient do independently? Like, can they move around? Because if it's a shortness of breath case, are they okay with walking? There's still some issue when they walk, and then now having difficulty in breathing. Is there such a thing? You just ask those things. Review of systems. Yes. I'm nearing the end. Kama nimewabo pole. I'm nearly done. Then I pass it on to Savimbi. So, CVS. This is where you ask anything in the world aside from RESP. CVS. Do they have chest pain? No. Do they have difficulty in breathing? No. Do they have syncope? Syncope is fainting due to a cardiac. Pre-syncope is the feeling of wanting to. Do they have palpitations? Beating, awareness of heartbeat. Do they have edema? Do they have orthopnea? GAT. Nausea, vomiting, diarrhea, abdominal pain, abdominal distension, stool consistency, color, frequency. You also ask about stool, by the way, guys. Dysphagia. Do they have difficulty swallowing? Or dinophagia. Do they have pain while swallowing? Urinary. How is the short call business? Frequency, is it normal? Color, is it normal? Volume, is it normal? Flank pain. Do they have pain on their sides? That's what we call flanks, on their sides. Do they have pain while urinating? Do they suddenly wake up at night because they want to go pee? Do they have urinary incontinence, what we call bedwetting, even at night or even during the day? Do they have that scenario where urine just flows? It's very embarrassing, so you have to ask this with a little bit of tact. Do they have terminal dribbling, hesitancy, any discharge whatsoever? Do they have, now you come to the CNS, do they have headaches, seizures, differences in either your vision, your hearing, your taste, or your nose? Do you have any disturbances? Okay, this stupid mosquito. Do you have any disturbances with your motor, your muscles, or your sensory features? Are you exhibiting any features of confusion, like in some cases, pneumonia would do that to someone? Do you have any musculoskeletal issues like joint pain, muscle pain, bone pain, any dermatological issues like lumps or rashes? Basically, you ask anything unrelated to that system until you find it. This is how doctors and consultants know that you have exhausted everything. Like you've asked your patient everything that there is. I think from there, oh yeah, usually you have to do a summary after this. Like you compile everything together from your biodata, your PC, and you highlight the important things in your HPI. Like this guy used to smoke. Unaandika hiyo. He was a known smoker for this long, smoking this many pack years. Important negatives. He did not have any history of travel to this area. Evil. And it should be very short, like two statements at most. Two statements. Like it should be very, and never forget to do a summary. Just like I've forgotten how to put the summary here. Never forget to do a summary. That's very important. And I think from there, I will pass it on to Savimbi. Can take it. Can take it from there. Let me stop sharing.
Hi guys. Can you see my presentation and can you hear me?
Yes, yes, we can.
Right, thanks. Okay, so now begins the general exam. So for the general exam, it's more or less the same. It's more or less the same thing that cuts across like multiple systems. So basically from the general exam, how we start off, you have to highlight the appearance of the patient. So you start off by, describe. So a good general exam, be one that has enough information for one to visualize a patient, even if they were blind. So, you'd walk into a room, you'd see a patient, you'd comment on the patient's gender, you'd comment on the patient's physical appearance. Things like gender. You'd comment on their race. You'd comment on uh, how old they appear to be. You'd comment on how, well nourished they are or whether they have a bad nutritional status. You'd comment about any sort of distress. With RESP, most of the time, it's mostly, like respiratory distress. So this can be, you can note this by, fled nasal, what is it? Like fed nostrils. You could also note by, increased breathing, increased work of breathing, coastal indrawing. So this is basically where the area between the ribs basically, is like drawn in so much because like they're using a lot of effort to breathe. They could also be using accessory muscles, the likes of sternocleidomastoid, abdominal muscles. So these are things you have to comment on, and these are things you have to bring out when you start your general exam. So remember, you should be able to actually help someone visualize a patient even if they blind. So you'd also comment on noises if you hear any, wheezing or stridor, wheezing in expiration, stridor in inspiration. You'd also have to comment on attachments around the patient. So things like oxygen and oxygen mask around the patient, these are key in telling you that whatever they have going on must be serious. You'd also comment on probably a plate of food they have beside them. If there's still lots of leftover food, then you might be able to make a comment on how they have no appetite. Um, Probably you'd find basins at the foot of their beds, probably with vomit or something like that. Yeah. Anyway, moving on. Now comes the Jacold. I'm sure you guys are familiar with this. So the J being jaundice, A being anemia, C being clubbing, the other C being chylomicria, O being edema, L being lymphadenopathy, W being wasting, and then D, dehydration. So for these, the different techniques on how to check. So for jaundice, mostly it's palmar and scleral jaundice. So one way to start is from the hands to the face and then work your way down to the feet. So this is the inverted J. Other people might do head to toe, but my preference is the inverted J. So you'd start by looking at, the palmar surface of the hands. So while looking at them, you'd be looking for, jaundice. So this is yellow discoloration of the palms. Another thing you'd be also looking in the palms is pallor. You don't say anemia, you say pallor. You'd be looking for pallor, so you'd compare, your own hands to theirs, assuming you're normal. So yeah. Another thing you could also check for is peripheral cyanosis. Now this is especially in the dorsal aspect of the hand, fingertips. So this is like blue discoloration. So this basically tells you there's poor ventilation. Like when blood is deoxygenated, it turns blue. So this actually points towards that. You could also look for clubbing. Now, for clubbing, the different stages of clubbing. There's the first stage where, nail bed is fluctuant. There's the next stage where the Shamrock's window is obliterated. And then there's a third stage where the Lovey bond angle is lost. And there's a fourth stage that appears like a drumstick. So this is telling of a chronic condition like COPD. Yeah, I think that's it for the hands. So now you work your way upwards. Also make sure you note temperature of the hands. So you compare from, the forearms move downwards. Usually warm hands point towards CO2 retention. So yeah. As you move upwards, you also take vitals, the pulse, blood pressure. When you're in the, what is it, auxiliary, you can also check for the temperature. And then you move to the eyes. Here you can check for conjunctival pallor. Here you can also check for scleral jaundice. Now the techniques for this, I think when we make time to like go to the ward, we can show you. Once you're done with the eyes, you've checked for pallor, you've checked for jaundice. You now move downwards to the mouth. Here in the mouth, you can check for pallor again. You can also check for cyanosis, central cyanosis to be more specific. You can also check for dehydration. You can also check for, yeah, that's about it. So with pallor, you can check the dorsum of the tongue. it's pale, might indicate pallor. You can also check for the mucosa in the mouth. If it's bluish, points to central cyanosis. And this is usually associated with like congenital heart defects. And then there's also some the oral mucosa. You also check for that. And then for dehydration, I think you guys already know how to check. You just check for like chapped lips or something. And then you move on to now the neck. So the neck here we have lymph nodes. So they're different groups, and you have to have mastered how to elicit lymphadenopathy, swollen lymph nodes, tender lymph nodes by the end of this rotation. So there's the different groups, the submental, submandibular, you have the parotid, you have cervical, anterior cervical, posterior cervical, supraclavicular, infraclavicular, and then don't forget the axillary lymph nodes. That one's a bit more technical on how to check. So still, we'll show you guys when we get to the wards. Okay, so now you're done with the axilla. Now you move on to the feet. So for the feet, this is where we usually check for edema. So there's patent edema and then there's non-patent edema. Our interest here is patent edema. So there's also a technique to check for this. One thing you should be careful. One thing you should take care to do is look at the patient's face when you squeeze, because wincing indicates pain. So just make sure there's no wince. Yeah, I think that's it for the general exam. Moving on. Now we go to the systemic exam. So for the systemic exam, there's an order for these things. It's inspection, palpation, percussion, and then auscultation, or IPA, if you want to abbreviate it. So for inspection, this, you do, what is it? You check the hands. So you check for color, you check for staining. Now this is nicotine staining, like tobacco staining. It's usually between the fingers, the way most cigarette smokers hold their cigarettes, with the two fingers, yeah. So sometimes they tend to be charred because of burns. Yeah. You also check for finger clubbing. So like I said, it points towards a more chronic condition like COPD. You can also check for flapping. So when there's a lot of CO2 retained, there's a certain flap. So to elicit this, you'll have to ask the patient to stretch out their hands, and then bend them back a bit, and then check for any flapping. There's also fine tremors. You still ask them to hold out their hands, probably place a piece of paper on top, and then check for any subtle movements. Moving on, you check for the respiratory rate. So this is done, at the foot of the bed, usually. Or you can just do it while standing next to the patient. So for this one, you'll have to do it in a subtle manner. You don't let the patient catch on what you're doing, because a lot of the time, I don't know if you guys can agree, but if someone's looking for your respiratory rate and they do inform you about what they're doing, then I don't know, there's a bit of a discrepancy. You probably start breathing faster or slower than normal. So we want to get an accurate measure as possible. So usually it's from 14 breaths to 16 breaths per minute, according to Hutchinson's. This is what we use in the wards. According to AMBUS, it's 12 to 20 breaths per minute. So anything above or below this range is indicative of respiratory failure. So you also check for the pulse and determine the rate and rhythm. So while inspecting, you check for the jugular venous pressure. So this is the jugular vein. It's located in the neck region. So there's also a technique for this. Now, this will also show you guys when we get to the ward. But an elevated GVP, the normal's less than 4 centimeters. An elevated one, indicates pulmonale or pulmonary hypertension. So basically, the CVS system is like it's an enclosed pressure system. So with pulmonary hypertension, if there's a buildup of pressure in the pulmonary vascular bed, that pressure is transmitted backwards into the right ventricle, then to the right atrium, then the vena cava, the vena cava, superior vena cava. So when this pressure is transmitted backwards, there's now a buildup of blood, and then the AVP is raised. So yeah, here it says also check for central cyanosis around the mouth. So upon inspection of the chest, what we're looking at, you start from the foot of the bed and then move onto the right side of the patient. All exams are done from the right side of the patient's bed. Always make sure you're at the right side of the patient's bed. You could be on the left, do everything right, but that small detail is what's going to, negate, all that you've done. So upon inspection of the chest, what we're looking for is the shape. We're checking for the symmetry. We're checking for the movement of the chest wall with breathing. You start from the foot of the bed and then move on to the patient's right side. So while you're at the patient's right side, you can get a closer look and check for any scars, therapeutic scars, any skin changes, and then you comment on that. So this is for make sure you do inspection for both anterior and posterior chest. Actually, make sure you do everything: inspection, palpation, percussion, and auscultation for the anterior and posterior chest. But to make it easy for the patient so as not to move back and forth, you could simply finish with the anterior chest, do inspection, palpation, percussion, auscultation for the anterior chest, and then move on to the posterior chest. Now for palpation. So our interest when it comes to palpation is the trachea, the apex, and chest expansion. So start with palpation of the trachea. There's a certain technique to palpate for a trachea to make sure it's not deviated. If it is, to elicit that. So there's some conditions that that bring about deviation of the trachea, contralaterally or ipsilaterally. So conditions like pneumothorax, where there's air from the outside that builds up the chest cavity and compresses the lung. This tends to push the trachea away from the pneumothorax. And then conditions like pleural effusions. And then the other conditions like lobar collapse and pneumonectomy. This is a removal of a lobe of the lung. So, and fibrosis. So these tend to, deviate the trachea ipsilaterally. So they pull it towards the affected side. After that, after you've, palpated for the trachea, now you palpate for the apex. So for the apex, it's normally found in the fifth intercostal space, the mid-clavicular line. It's deviated. This points towards a displaced mediastinum. And there are also other conditions that bring this about. Things like malignancy, the growth could shift the mediastinum. So assuming the trachea is deviated to the left and the apex is also deviated to the left, this paints a clear picture of mediastinal shift. So after you've palpated for the apex, now comes chest expansion. So for this one, there's techniques to do that. Your fingers and hands have to be placed a certain way. There's 3 areas where we check for this. In the anterior chest, we check supramammary, mammary, and inframammary. So you just place your hands together, your thumbs, not on the patient's chest, but slightly okay, keep them afloat a bit. Then you ask the patient to like take deep breaths in, deep breaths out, and now you can check for the relative expansion. In cases like pulmonary fibrosis, you notice a reduced expansion in the affected side. It would be asymmetrical. Any consolidation would bring about asymmetrical reduced chest expansion on the affected side. After you've checked for relative chest expansion, now you check for absolute chest expansion. Now this is where the measuring tapes come in handy. So you're going to like, ask the patient to, lift up a bit, let the tape measure around, ask them to breathe in, breathe out, and then notice the difference in the expansion. So normal is about 5 centimeters. Oh, and another thing to note, pain, tenderness. Make sure you ask the patient if they're experiencing any sort of pain or tenderness in the chest area and try to avoid that area as much as possible. Or if it's unavoidable, try to palpate it last. Same thing goes for GI. Now comes percussion. Now, I don't know if you've seen or you've tried it, but there's also a technique where you place your non-dominant hand on the area you wish to percuss, and then you strike the distal interphalangeal joint, the middle finger of your dominant hand. So I don't know if you guys can visualize that, but we'll do that in the wards when we get time. So the thing is, there are also areas to percuss. I don't know if you guys know the outline of a vest, but where we'll be percussing is along the outline of a vest. Just picture someone wearing a vest, and then the outline of it is where we'll be percussing. Reason being, the other organs like the heart, it takes up, takes up an area, the left chest. So I mean, that would be counterproductive, percussing over the heart. Like you'd assume, oh, it's dull, it must be consolidation, but it's just the heart, and that's what it's supposed to be. So, for the percussion, sites include supraclavicular and infraclavicular areas. So, normal sound is resonant. I don't know if you guys know what a resonant sound sounds like. We'll also check. We'll get to that one. And then there's also hyperresonance, and this usually points to a pneumothorax because of excess air in that area. Because sound, it's better. It's better audible in air. And then dull, a dull sound points towards consolidation. So this could be an effusion, could be a tumor. And then there's a stony dullness, which is characteristic of pleural effusion. If you look in Hutchinson's, it explains what stony dullness is. Sounds like, percussing a barrel filled with water. So now on to auscultation. So auscultation is also, it's a very important bit. This and chest expansion, those are very important bits in the respiratory exam. So for auscultation, there's two sounds mostly. There's two sounds you need to know: the vesicular breathing sounds and the bronchial breath sounds. So bronchial breath sounds anywhere apart from the bronchial area. If you hear these, it's usually points to trouble. Vesicular breathing sounds are normal breath sounds. If you guys have stethoscopes, you can just try it on yourself. They are usually very quiet, and then bronchial breath sounds are turbulent. For reference, you could also, like auscultate, your trachea to hear what a bronchial breath sounds like, and then check other areas of the lungs, of the chest, for a similar sound. Then there's the vocal fremitus. So while you're auscultating, you could ask the patient to, utter the words 99, 99, something like that. Now, in areas of consolidation, they're louder. And then in areas of what is usually more quiet. So, another finding would be a pleural rub. So this is associated with infection, pruritus. When you ask the patient to breathe, you just hear a rub. You're just like rubbing your fingers together. It's subtle. And you could also hear wheezes, associated with asthma, COPD, infection. Remember, with crackles sound like bubble wrap, popping bubble wrap. So there's fine crackles and there's coarse crackles. So these point towards pulmonary fibrosis. So for fibrosis, it's usually fine crackles. And then for effusions, it's usually coarse crackles. So here's a table that puts it all together. Here are some of the common conditions, and here are some of the expected findings. So like for asthma here, on inspection, you'd notice the patient is using accessory muscles to breathe, is having a difficult time to, catch the breath. Upon palpation, you might notice there's reduced chest expansion. Upon percussion, you also might notice an increased resonance. On auscultation, you might hear an expiratory whiz. Other conditions like COPD, you'd notice an increased anterior posterior diameter, better known as a barrel chest. You'll know it when you see it. And then you might also notice an use of accessory muscles, reduced chest expansion, increased resonance, and diffuse breath sounds, inspiratory crackles. So one thing I forgot to mention up there is proper positioning. Each systemic exam has unique positions the patient's supposed to be in. So for the respiratory exam, ideally a patient's supposed to be seated at a 45-degree angle, not lying down. That's in GIT. The same goes to a CVS exam. They're supposed to be at a 45-degree angle, comfortable, properly exposed. So for resp, proper exposure, topless. That's for guys. For ladies, it's also topless, but you know, if they have like a shawl or something like that, they can cover up as you do other parts, then just undress as you finish off. So here I have an example, a sample history. So this is what David has been talking about. So here we have the biodata. See it. Hello?
Hello.
Hello.
Yeah, I see it.
Yes.
Right. So here we have the biodata. In the biodata, this captures, like important points in the biodata. Name, age. Age is very important because there's some conditions that are predominant in certain age groups. Gender is also important because some conditions, have a preference for one gender. Residence, like David said earlier, residence is very important because this can give you an idea of what factors are exposed to, what risk factors are exposed to. Like say someone who resides in Kibera, might be predisposed to like respiratory conditions because there's a dump site not far away from where they live. Occupation, there are a lot of occupational diseases, like coal mining, farming, exposure to chemicals, like in farming. Yeah. Date of admission is also important. Marital status is also important. I think it's supposed to be a bit higher up. My data is supposed to be, supposed to finish off with the date of admission. One thing about consultants is they like it when you tell them how long ago, not a date. Like no consultant wants to be told, this patient was admitted on the 1st of October. No, they'd rather be told 6 days ago. So once you're done with the biodata, now comes the present and consent. So keep it simple, layman terms. Also include how long they've been ailing from this. So here we have a cough for 2 weeks. Now comes the HPI, the history of the presenting issue. Here it starts with, okay, can someone read this for us? That way at least I'll get you guys to, take part.
The HPI or the presenting complaint?
The HPI. Could you read this paragraph and then I'll ask someone else to read the next paragraph and then like that.
Okay, so I'll start the HPI. Patient was well until 2 weeks ago when he reported the onset of a cough that began gradually. Initially mild and infrequent, the cough has progressively worsened, becoming more persistent and bothersome. The cough was predominantly dry, though he occasionally produced small amounts of clear or white phlegm. About a week later, the sputum production increased and took on a yellow tinge, with only one instant of blood-tinged sputum. He estimated producing about half a teaspoon to later 1 tablespoon of sputum per episode. The cough occurred at no particular time of the day. It also worsened with physical exertion and exposure to cold.
Thank you. So from this paragraph, for the presenting issue, which is cough, it explains the onset. Here, the onset is gradual or insidious. Then as you move on, it also explains the frequency of this cough. It was initially infrequent, then became more persistent. That's also, like progression. I remember someone was asking about how you'd ask about progression. There's your answer. That's how like you'd put it. Also, this other statement, it was predominantly dry, occasionally produced small amounts of clear or white phlegm. Then a week later, production increased and took on a yellowish tinge. Only one instance of blood tinged sputum, estimated producing half a teaspoon to later 1 tablespoon per episode. So for that person who was asking about progression, who was it?
I asked about that.
Thank you. So you asked about progression. So from this, like paragraph, what comment would you make about the progression? Would you say it's progressively worsening? Is it constant, or is it getting better? What would you say?
It's progressively worsening.
Yes. So thank you. So yeah, you see, like that captures, like okay, like in short, you've told your consultant, assuming you're presenting to a consultant, you've told them that it's progressively worsening without actually telling them it's progressively worsening. So okay. And then the cough occurred at no particular time of the day. So this is also an important question to ask, as David highlighted, in cases like asthma, it's usually worse at night and early in the morning. So by this statement alone, occurred at no particular time of the day, I think it's safe to rule out asthma. It also worsened with physical exertion and exposure to the cold. here we've captured exacerbating factors very nicely. Someone else, please read this paragraph. The cough was associated with.
The cough was associated with a low-grade fever persistent over the 1 week prior to admission, along with intermittent chills. Although he denies significant chest pain, he described a dull, aching discomfort in the right lower chest that worsened with deep breathing or coughing. He had also experienced shortness of breath, particularly during exertion, but denied any wheezing.
Thank you. So this paragraph it captures very nicely associated symptoms. Like I said before, sometimes you might have way too many presenting complaints. Ideally, you should have like 3 to 4. More just, makes it, I don't know, like presenting issue should be really short. Like that section should be really short. If you have any more, then it's going to, like lengthen the whole thing, and then it raises questions, which we don't. And then again, if a presenting complaint isn't really strong enough to stand by itself, you could just bring it down here and, like associate it to, like a more urgent issue, presenting issue, yeah. So here we can see it's associated with a low-grade fever, and we also got the timeline. 1 week prior to admission. We also got intermittent chills. There's also a chest pain here, though he denies that it's significant. He describes it as dull, aching discomfort in the right lower chest that worsened breathing, coughing. So chest pain that worsens with deep breathing or coughing. This is pleuritic. David had mentioned that before. Or pleurisy. Moving on, he also experienced a shortness of breath, particularly during exertion, but denied any wheezing. So yeah, safely ruled out asthma. Okay. Someone else, please read the rest.
I can read.
Yeah, yes, please.
The patient confirmed a recent upper respiratory infection. He recalls having a runny nose and nasal congestion a few days before the onset of the cough. He has no history of chronic lung conditions such as asthma or COPD. He denied any history of smoking, both actively and passively. He works in an office environment where a few colleagues had recently been off work due to a cold. He has not traveled recently. What's the next part? Oh, okay. He's not
Yeah,
on,
I just finished.
okay. He's not on any medications known to cause a cough as a side effect, such as ACE inhibitors. He denied receiving recent vaccinations, including the influenza or pneumococcal vaccine. Since admission, he's been given supplemental oxygen, antipyretics, and antibiotics. He's had blood drawn, sputum collected, and CXR done. He's currently doing better as symptoms have subsided, and he's ambulatory.
Thank you. So here, the patient confirmed a recent upper respiratory infection. Then patient described it as runny nose with nasal congestion, and this was before the onset of a cough. Patient has no other chronic lung conditions, the likes of asthma and COPD. And this patient is not, patient has no history of smoking. So by the time, you're done with this paragraph, I think, you already have a suspect. You have something, you have a suspect, like what brought about this condition. And here, the runny nose and the nasal congestion, this points towards, flu 4. And now this, like starts to paint a picture of a pneumonia. So this person had like, say the flu, influenza, then it made its way down to the lungs where it brought about a pneumonia. And by definition, a pneumonia is acute, infection of the lung, parenchyma. Now it brings about these presentations, cough, it brings about the fever, it brings about the chest pain, it brings about the difficulty breathing. Yeah. And then moving on, patient confirmed not being on any medication, known to cause a cough as a side effect, like of ACE inhibitors, as David mentioned. He also did not receive any vaccinations, like of influenza, pneumococcal. So you can see this patient's predisposed to influenza. And then now to finish off the HPI, we want to know how the patient currently is doing. I mean, you want to know how the patient's doing at the moment. You also want to know what has been done for the patient. So this last paragraph captures that really nicely. Since admission, he's been given supplemental oxygen, antipyretics, and antibiotics. Supplemental oxygen, for the difficulty in breathing, shortness of breath. Antipyretics for the low-grade fever, and antibiotics because of the infection of the lungs. You could also what is it? Also the sputum points towards the lung infection. And then now here, he has had blood drawn, sputum collected, and a chest X-ray done. So that's what has been done for this patient. And then currently he's doing better as the symptoms have subsided, and he is ambulatory. He's moving about. So yeah, so that's what AHPI would look like, the respiratory ward. So are there any questions? That's it. Any questions?
I have a question.
Yeah.
If you mention that he denied any history of smoking in the HPI, do you also have to mention it again in the if it's family social history part? Also the part of the colleagues. Okay, yeah, the smoking part.
Okay. So smoking is very important. In surgery, they usually put it in family social history. Social activities they partake. That's why they usually put smoking. But you see, for IMED, smoking could be the cause of a lot of things. And one thing about the HPI is if you have reason to suspect it's the cause, you have to bring it in the HPI. The hallmark of a good HPI should be you should basically be able to, have a working diagnosis by the time one's finished reading the HPI alone. Forget the past medical history, forget the family social obs and gyne. By the time one is done reading the HPI, you should already have, a diagnosis in your head. Now that's the hallmark of a good HPI. I also have another document here. Have I answered your question?
Yes, you have. Thank you.
You're welcome. Anyone else with a question? Anyone? Okay, so can you see this other document of shared history taking tips?
Yes.
Okay, so this was a document Dr. Sheikh drafted. He's a consultant in 6B GIT. Okay, you'll see him eventually. He'll show up. So here he highlighted 6 important things that must come out in the HPI. So we have the systemic analysis of symptoms. Now this includes your operates, your Socrates, as David mentioned. This is where it comes in. And then you have associated with other relevant symptoms, the likes of fever, hotness of body. Usually don't say fever, you say hotness of body. likes of chills, whatnot. And then you identify the risk factors, possible culprits, suspects, things that may cause, this patient to present like this. And then now comes important negatives. So you exclude other possible clinical explanations. And then you also have to bring out the patient's contact with the healthcare system, whether they're referral or not, but that should come in, your date of admission brought in as a referral on. And then you also have to bring out functional deterioration. So if you compare with the history we just went through, sample history, we have a cough. Then there was a systemic analysis of the cough. We got the onset, we got the progression of the cough, we got the characteristics of the cough, initially dry and then productive. We also got relieving and exacerbating factors, exacerbated by exposure to the cold, exertion. But I don't think there were relieving factors about that. Yeah, there's no such thing as a localized cough or global cough. And then moving on, we associated it with other relevant symptoms. That was the fever. That was also the chest discomfort. Those were relevant symptoms that we associated it with. And then we tried to identify the risk factors. So risk factors, one, this patient is old. I don't know if you guys noted that from the biodata. This is a 68-year-old. So that's a risk factor. And then another risk factor is there was a cold that was going that was, there was a cold going about in the workplace. Colleagues, came down with a cold, and now it finally got to him. So that's a possible etiological factor. And then important negatives, we noted that this patient did not have any wheezing. So that ruled out asthma very nicely for us. There should be more, but, we'll get to that later. There should be more. There should be a couple, to make it lengthy enough. And then we also spoke about contact with the healthcare system. We spoke about how this patient had, blood drawn, chest x-ray, sputum, how they're given oxygen, antibiotics, antipyretics. So we touched on contact with the healthcare system. And then functional deterioration, we spoke about how this illness affected the person. They could not exert themselves as well as they did, as well as they could before. We also spoke about how they're doing now. Symptoms have subsided since, currently ambulatory. So yeah. So these 6 important things have been captured in that sample history. Although ideally a history is supposed to be more lengthy than that. That's something good to start from. So yeah. Any questions? So I'm assuming there are no questions. Yeah, we can call it a day then.
Thank you guys for
David.
showing up. Hope you guys have learned to take a history, and hope to see you again. I think we'll be with you tomorrow. Yeah, we'll share the presentation. We'll be with you tomorrow for endocrine. Yeah. Same time. Same link, same breakout room, everything. Yeah.
Bye, guys.